I'm on the slides here mode. I'll start presenting.
Sure.
So I'll be discussing the role of radiotherapy in the non-small cell lung cancer, especially the adjuvant radiotherapy in the non-small cell lung cancer. So as we all know that standard of care for stage 1 and stage 2 non-small cell lung cancer is a complete surgical resection with possible addition of adjuvant chemotherapy. For stage 3, significant controversies exist regarding the optimal management. For select stage 3A with resectable disease, NSCT or NACT followed by RT can be used. For unresectable stage 3 disease, concurrent chemoradiotherapy is usually given for the fit patient and sequential chemotherapy and radiotherapy for those who cannot tolerate concurrent chemoradiation. For stage 4 disease, systemic chemotherapy or urgent palliative radiotherapy for symptomatic metastasis or local disease is offered. So what is the rationale for giving the adjuvant therapy? So we all know that non-small cell lung cancer constitutes approximately 80% of the lung cancer, and most long-term survivors are those patients who had complete surgical resection. However, complete surgical resection can be achieved in about 30% of cases only, and that too in India, as most of the patients present in advanced stage, surgical resection is possible in about 10% of patients only. So,
Rambha, sorry for interrupting. Can you share your slide in the full view?
Sir, I'm trying, but it's not.
Rambha, just go to the bottom, and here you can see there is this full slide.
Yes,
yes, ma'am. Thank you, ma'am.
Yes. So even with surgical dissection, complete surgical dissection, there is always a risk of locoregional or distant recurrence, and this incidence is to the tune of 20% in stage 1 completely surgically resected patient, and it can go up to 50% in stage 2 patients. We all know that the most common site for intrathoracic failure after surgical resection is along the surgical span and in the mediastinal node. In stage 3A and selected stage 3B patients, the 5-year survival is to the tune of 20 to 25%, and also there is very high risk of metastatic or local recurrence. Distant failure is to the tune of 30 to 50%, and brain metastasis can occur in 20 to 32% of patients. Local failure rate at 3 years in surgical series varies from 15 to 40%, and in the chemoradiotherapy series, locoregional progression rate is around 30%. So, as there is a very high risk of locoregional recurrence or distant metastasis, there is a need for adjuvant treatment such as chemotherapy or radiotherapy, and it has been evaluated in order to improve the prognosis in non-small cell lung cancer. So what is the evidence in favor of post-op radiotherapy? So the first landmark trial, which was a meta-analysis by non-small cell lung cancer collaborative group published in BMJ in 1995. This was basically a trial to show the role of adjuvant cisplatin in non-small cell lung cancer, and it showed absolute survival benefit of 5% with addition of cisplatin-based chemotherapy in completely surgically resected non-small cell lung cancer. However, despite this, the local tumor failure, even with surgery and adjuvant chemotherapy, was to the tune of 20 to 40%, and hence there was a need for further local therapy, and role of post-op radiotherapy was evaluated. Now, these were the retrospective studies on post-operative radiotherapy before 1995, and most of the study, they have used radiotherapy to the dose of 40 gray to 66 gray, and some of the trials have actually shown very good results with addition of post-operative radiotherapy to the tune. Maximum was seen in the study by the Patterson et al., where 5-year actual survival was 56%. So these study formed the basis for the further study on the role of adjuvant radiotherapy in the non-small cell lung cancer, and the landmark trial was Port meta-analysis of Medical Research Council, which was published in Lancet 1998. This trial included 2,128 patients from 9 trials, and the median follow-up was 3.9 years. This trial showed significant adverse effect of post-op radiotherapy on survival with 21% relative increase in the risk of death. This was equivalent to absolute detriment of 7% at 2 years, reducing the overall survival from 55% to 48%. The subgroup analysis suggested that detrimental effect was more pronounced for patients with stage 1 to 2 N0, N1 disease, whereas for stage 3 N2 patient, there was no clear evidence of an adverse effect. There was certain criticism to this study that 25% of patients who had PN0 disease actually did not need adjuvant radiotherapy. There was no quality control in the radiotherapy arm, and it was felt to be inferior to the modern standard. Most of the patients were treated to target volume using older cobalt-60 equipment to field designed under fluoroscopy, and the detriment in overall survival seen with post-op radiotherapy was felt largely due to excessive late toxicity to normal tissue, particularly the heart and the lungs. So this trial it was disappointing from the point of view of a radiation oncologist. So, and in this trial, nine trials were included, and now after this trial, there was an updated analysis of this by the same group, and in this trial, they included one Italian trial also. So the previous 4 analysis, they had included 9 trials, but in this study, they included 10 trials, one from the Italy as well. And this trial was published in Lung Cancer 2005, and this showed that this again showed PORT to be detrimental with 18% relative increase in the risk of death. PORT was more harmful in stage 1 than in stage 2. However, there was some relief from the radiation oncologist point of view, that the SEER analysis which was published in Journal of Clinical Oncology in 2006. This SEER analysis included 7,400 patients with stage 2 and 3 resected non-small cell lung cancer. In this analysis, PORT showed improved 5-year overall survival for pathologically N2 patient, 27 versus 20% in favor of post-operative radiotherapy. However, this study also showed reduced overall survival for pathologically N0 and pathologically N1 disease. Now, this ANITA trial, this trial was basically a chemotherapy trial, and this trial was intended to assess the efficacy of cisplatin and vinorelbine in adjuvant setting in a patient with non-small cell lung cancer of stage 1B to 3A post-surgery. So this trial included 840 patients, and all these patients post-surgery, they were randomized to receive chemotherapy, cisplatin and vinorelbine, or no chemotherapy. Radiation was at the discretion of the treating site. The result of this study was published in 2006 in Lancet Oncology, and this study showed that overall survival at 5 years with chemotherapy improved by 8.6%, which was maintained at 7 years. A subset analysis of this ANITA trial, which was published in IGROBQ in 2008, showed that patients with PN2 disease who received post-operative radiotherapy, both in the chemotherapy arm or in the observation arm, has a improvement in the median survival from 23.8% to 23.8 months to 47.4 months in favor of post-operative radiotherapy, and in observation arm 12.7 to 22.7 months in favor of post-op radiotherapy. So this retrospective evaluation suggests a positive effect of PORT in pathologically N2 disease and a negative effect on pathologically N1 disease when patients receive adjuvant chemotherapy. Now, so far there was no randomized trial, and this was a phase 2 trial by RTOG group, RTOG 9705, which was published in Journal of Clinical Oncology in 2005. And this trial was a phase 2 study assessing the efficacy of adjuvant paclitaxel and carboplatin along with thoracic radiotherapy in resected stage 2 and 3 in non-small cell lung cancer. This study showed a median overall survival time was 56.3 months with 1, 2, and 3-year survival rate of 86%, 70, and 61% in post-op radiotherapy arm, and progression-free improvement in progression-free survival with 1, 2, and 3-year progression-free survival rate being 70%, 57, and 50%. And the result of this study was comparable to Eastern Cooperative Oncology Group 3590. So this result showed an improved overall survival and progression-free survival in the group of patients who received post-operative radiotherapy or adjuvant treatment. So over the period, because all these studies were meta-analysis or SEER analysis, over the period there was a need for assessing the role of radiotherapy in the non-small cell lung cancer. So this was a study by Corso et al., which was published in JTO in 2015. And this is basically included patients from the National Cancer Database. So this study included 30,552 patients treated between 1998 and 2006. In this study also, it was shown that addition of post-operative radiotherapy has favorable effect on the N2 disease, a patient with N2 disease. The 5-year overall survival increased from 27.8% to 34.1%. However, this was detrimental in patients with N0 disease and N1 disease.
Dr. Rambha, 2 more minutes.
Yes, sir. Now, role of radiotherapy in patients with incompletely resected lung cancer. So this was again assessed in a study by post-operative radiation therapy is associated with improved overall survival in completely resected stage 2 and 3 non-small cell lung cancer patients, was published in JCO by Wong et al. And this study showed that PORT is significantly associated with improved survival in patients with incompletely resected stage 2 or 3 N0, N2 non-small cell lung cancer. These are the Kaplan-Meier survival curve for patient in this study, and it shows that in all stages, patient with positive margin, there was improvement with the addition of the post-operative radiotherapy. Now the lung art trial, this is the most awaited trial, and this trial basically is intended to assess the efficacy of post-operative radiotherapy in completely resected non-small cell lung cancer with proven N2 disease. And the study was intended to include 700 patients to show a 10% disease-free survival difference at 3 years. So in this study, the patients were randomized to receive no mediastinal RT or conformal mediastinal post-operative radiotherapy, 54 gain 27 fraction to 30 fraction. So recently, the primary endpoint analysis of lung art trial was presented at ESMO 2020 on 20th September 2020. In this analysis, they included 501 patients. In post-operative arm, there was 252 patients, control arm 249 patients. Safety analysis was carried out in 487 patients. So this study shows that disease-free survival or overall survival does not improve with the addition of the PORT in non-small cell lung cancer. So to conclude, the authors commented that post-operative radiotherapy can be recommended for all patients with mediastinal nodal invasion. This is useful for some patients as it reduces the mediastinal relapse by 50%. So in summary, the indication for post-operative radiotherapy remains stage 1 and 2 with closed or positive surgical margin. In stage 3A, closed margin, positive margin, N2 disease and nodal extracapsular extension may be controversial after the lung art trial. So to conclude, the RT plays an important role as an adjuvant modality in closed or positive margin in stage 1 to 3A non-small cell lung cancer. The interim analysis of lung art trial shows post-operative therapy cannot be recommended for all patients with mediastinal nodal disease. It can be included judiciously for patients with high-risk disease. The final result of lung art trial may have an impact on role of post-operative radiotherapy in N2 nodal disease. Thank you.